trusts by abs.
Hello, everybody. Welcome to our November Humber Trust Board meeting, and to those who've tuned in, welcome. We start today with apologies for absence. I haven't received any apologies. Are there anybody? Apologies? No, I think we have a full house. And declarations of interest. As is customary, any further changes to declarations, please notify the Trust Secretary. And if any items on the agenda present anyone with a potential conflict of interest, please declare your interest and remove yourself from the meeting for that item. We move on to minutes of the meeting held on the 27th of October 2021 and the action log and matters arising. Are there any corrections to the minutes or any matters arising? Yes, Hilary.
Thank you. On page 16 of the board pack, item 213.21, second paragraph down, where in the middle it says closed culture was another area highlighted in the report. There's a typo there because it should be peer review process, but it reads as if it's the organisation that's the subject of the report that's doing the work when actually it's ourselves. So I've got some other words there just to pop in there, which is closed culture was an area highlighted in the report. The Trust has raised awareness of closed cultures across teams and is testing staff understanding and awareness via the peer review process. If I send those words to Jenny for the minutes, if that's okay with the board.
Yeah, that sounds
to clarify
fine.
that section.
Thanks very much, Hilary. Any other comments or corrections? No? Then those are approved by the board? Great. Anything on the actions arising, the actions log? I think they're all covered. Thank you very much. Right, we move on now to Chief Executive's report.
Yeah, thank you, Chair. Good morning, everybody. I will trust that people have read the report. As usual, I'll pick out a couple of headlines and then obviously open it up to my colleagues, my direct colleagues, and then questions. It was quite an interesting month, a busy month as usual. I've tried to capture some of the headlines in there. What was really interesting was being asked to be a part of the appointment panel for the Deputy Chief Constable of North Yorkshire. And I've mentioned it was a skills-based approach because that was different to the competency-based approach that we use a lot in the health service. That was quite a different approach, but that was a really interesting experience for myself and all for the police and the organisation's relationship. There's a lot in there in relationship to the strategy. We've amended the timelines just a little bit in relationship to ensuring that we have really continued engagement, and I thank everybody that's been involved in that work up to now. It's been a huge exercise, and I thank Pete and Lynn particularly and their teams for facilitating that, and certainly Pete's team, and we'll continue to do that, and we'll continue to have those non-exec director sessions as well, but also the wider stakeholder sessions, and we will get the final report, the final strategy by the end of July 22, because ours runs out at the end of 22. So I think hopefully that will link into the integrated care system as well. It's great news, and congratulations to Steve's team, and particularly Pete Cook for the Skills for Health kite mark. That's in the Director of Workforce report, but I've also popped it in my report as well, because that's a huge undertaking. I used to be a non-exec at the Skills for Health, and I know the work that goes into that, and it's not insignificant. Also great news, awards continue to come for Inspire, as I've mentioned, but also continue to get awards across the organisation. And this year was the first time the region, through Margaret Kitchen and her team, had done the Regional Healthcare Support Worker Awards. And we were really successful. Actually, we got 2 winners, which is absolutely fantastic. Dave Edgar from Newbridges, who got the Rising Star. And I've spoken to both Dave and Matt, and then Matt from the crisis team for the technology award. So that's great news. Lots of work continues in patient and public involvement, as I've mentioned in there. And there's quite a long report about the lecture theatre, because the executive management team have decided that we need to bring that back into the organisation in relationship to education and training now. It's been out a long time, but thanks to John and the team, and the pharmacy team, we've done a report in there just to say the huge amounts of work that has gone in the lecture theatre as the vaccination centre. So it's with sadness that we've done the vaccination centre down, because it's done some great work, but also I think positive as well going forward. So I'll leave you to have a look at that. Lots of work on the COVID report that Lynn can answer questions on if you wish to. Just to say that Steve is the SRO for the mandatory vaccinations of healthcare workers. That has to be in from April, and we continue to progress that work at the moment. If you remember, we've done the initial part with our social care staff and our staff going into social care residents. We now need to look at the totality of the organisation. So we'll give you a full report in January, but that work has started. We've done a separate winter report now to the COVID, and we'll continue to do that throughout winter, because as we know, it's going to be a really difficult, really challenging winter. We're already looking at business continuity, both within the organisation. Lots of organisations across the patch are at Opal, really high Opal levels, which is how they grade the capacity issues. But we're also having a mental health winter summit alongside the system summit for the whole of the system, just to see from a mental health perspective if there's anything else that we can be doing as providers across the system. It was really great news to get Market Wheaton CQC report, which was good. So I thank all the team, and I think the board will acknowledge the amount of work that's gone on there, and it was really pleasing to see that, and actually very limited actions from the report, which was really because there is a report on the board further down. There's been a lot of media which is in there, which you can have a look at, and I've done a couple of reports and publications for the Health Service Journal. So one's already been in, I think one's due to go in the next couple of weeks. So I thank the team for that. The policies, there's two policies. I think they're on page 43 of the report, of the main pack of the report. One change, I think we've spoken to most people now about the policies. The executive management team weren't really having a detailed understanding of some of the policy changes, because if you weren't at the committee, you didn't see what was changing. So we've enacted back to a little bit what we were before, which is the executive management team being the approving committee, but then it coming to board. So that's the document control policy change. And then there's a tissue viability policy and prevention and management of wounds policy. So they're both for ratification today. I know there's a lot there, but it has been a busy month. I'll hand over to my director colleagues if they want to highlight anything. And then, as usual, chair over to comments.
Thanks very much, Michelle. Of course, we had the research conference and the quality improvement week, which was great, and I was glad to be involved in those as well. Are the directors who'd like to add anything go first? Lynn?
It's just to pick up, as Michelle says, around sort of the COVID report particularly. So pressures are still very high, as I've been reporting elsewhere across the system. Overall, we've been operating between our operational pressures level between sort of 2 and 3, mainly over the last month. Our COVID-related staff absence is thankfully stable and fairly low at the moment, despite the fact that obviously we've got still significant infection circulating in our communities. The pressures are related, though, however, to staffing availability. I think it's a combination of non-COVID related absence, which we'll see in the performance report across some of our inpatient areas, and the vacancy position as well. Obviously, we continue to do lots of work around that. As you can see from the winter report later, we have got some additional funding to fund some of those pressures over winter as well. But it's the staffing position that continues to be sort of the area for focus. And I think Michelle's right to indicate that we will do our utmost to make sure that we're in a position to maintain our services safely. But there's a reason why we've got robust business continuity plans ready to use for when they're required. And obviously, we continue to have our various measures in place to oversee the pressures sort of operationally and through our COVID group as well.
Thanks very much, Lynn. Any of the other directors like to add something before we open up for questions? Michelle, I can see.
Can I just add quickly, Chair, to the communication section? You've already referred to the Humber Youth Action Group, and the team have been working on their branding, but the work is continuing, and we're supporting some young people to manage their own Instagram accounts. Again, another month of high positive news stories, 25, which is fantastic. Awareness days, another busy month with, for example, QI, International Stress Awareness Week. And finally, I know Michelle touched on it, but some great work in the trust that's been awards. In 2021 alone, we've had 10 awards in addition to 6 shortlisted places. In a normal year, that would be great. In a year with the additional challenges of COVID, that's a fantastic achievement of staff.
Thanks very much, Michelle. And I'm sure on behalf of the board, we sort of send our congratulations to everybody who's won those awards and the work they've put into it just to get nominated as well, I'd have to say. Anybody else? Okay. Pete, did you want to come in then?
Just one quick one.
Before I take questions. Yeah, go on.
Just the whole City Council 0 to 19 tender, we received notification at the end of last week that that timetable is likely to slip because they're undertaking some clarification. So I just thought it'd be worthwhile pointing that out since we put the date in the report.
Okay, thanks very much, Pete. Peter.
I just wanted to say really well done on a couple of things within the report. First of all, highlight Maester Lodge, the extra 5 beds there, and the work on the therapeutic garden. It's really important that older persons' mental health is delivered within the Hull and East Riding area, and we can now, with our expanded bed base, repatriate some of the patients who were a little bit further afield. So that's really good news. I'd perhaps just ask, because we've not been able to visit that, perhaps we could have some pictures of the scheme at some point. It would be very useful. That's a good news story. And just to reiterate what Michelle said about Market Wheat and with the CQC, because that's been an area of concern for various reasons at Market Wheat, and to get that really good positive news, it is fantastic. And I'm hoping that the team have been duly congratulated. I think the board should do that, and we should develop a comms plan as well with, I know we're doing Market Wheat newsletter, and that should certainly be included within that, so that those who read the newsletter locally can read that good news.
Thanks, Peter. I think Michelle just wanted to add something to that.
Yeah, great points. And then it might be actually good to do a bit of a bit of a virtual tour around Maester, so we can send a video around. So I'll look to Pete and Lynn if you can facilitate that, because that'd be quite helpful, and put it on our website as well, and get that going. Market Wheat, absolutely. Both myself and the chair have actually written to each individual member of staff personally. To thank them for their work over the last few months, particularly because it's been particularly challenging, but also on the really good rating from the CQC. And one of the things, I just had a conversation with comms yesterday just to make sure that we do that really larger push on where we do get CQC general practice. I think it is putting global, but I think we probably just need to do something that's a bit more highlighted. So we'll do that, but some really good points, thanks. But we'll get the video sorted out.
Brilliant, great. You must have some before and after videos. Next time we're doing a refurb, maybe get in there and do the befores and then afterwards.
We might be able to put something together a little bit, but yeah, that's not a bad idea. But we'll certainly get after.
Mike.
Thank you. I've got two, one for Steve and one for Pete, if that's all right. For Steve, it's concerned the staff survey on page 42. Some excellent stuff in there. Trust currently above the national average for response rates. Workforce and OD at 85%, Steve, as I would expect, and quality. And then things drop off a cliff a little bit, and we've got other, particularly frontline departments, who perhaps the last thing on their agenda when they come to work in the morning, afternoon or evening is to fill in the staff survey. But it's really important, because when we come to analyse that at this board, we'll look at where the issues are by department, and I'm just wondering what extra work, even though you're doing so well, can be put into the ones who haven't filled in the staff survey to support them and to secure that half an hour or how long it takes to do it.
Steve?
Yeah, thanks, Mike. And just the updated figures are, we're at 43%, which is what we achieved last year as of last week. So, and still another weeks ago. So I think that's great overall. In relation to the point that you make, there's been commitments through EMT to give people protected time to complete that. So those messages have gone out consistently about speak to your manager if you're not getting that time, escalate that if that's not the case. So those messages have gone out. With regards to sort of specific actions, Lynn probably is best to talk about what each of the different areas have done, the frontline areas have done. Lynn, do you want to pick those up?
Yeah, so leading on from last year, as Steve says, I think the divisions have taken very active approaches around staff surveys. So following on from last year, as many of the divisions have sort of focus groups, for example, with staff completion of the survey has been a focus of that as well. So those have been ongoing. So I know managers are raising this with staff. We would obviously like, to have the highest level of completion of the surveys as possible. So those messages are going out consistently and supported through a variety of other mechanisms too.
Thanks very much. And there was no criticism at all of my question. It's just about how do we just do more. Next one, if it's okay, Chair, is for Pete, and it's about cyber security. And it's a very basic question, Pete. I know my local hospital had an outage, well, not power outage, an IT outage for 24 hours. They did get through it, and 24 hours later, so 48 in total, things were back to normal. But I just wanted the basic assurance that if our IT systems drop tomorrow, despite all of this, we've got systems in place to keep running and keep providing patient care.
I think there's probably two parts to that question, isn't there, Mike? I guess digitally or IT-wise, we have backup solution because we have the ability to route our network via Whitby. So we kind of extended our infrastructure to give us that backup if we lost one of our main servers. But then operationally, and Lynn might want to come in, obviously when we had the WannaCry attack probably 4 or 5 years ago, and we did lose our systems, we did revert back to paper backup systems and on-site access for electronic records. And if you wanted to add anything, Clem.
Yeah, so obviously through the business continuity and the emergency planning process, we look at this area as well as you would expect us to, Mike. In the last sort of 18 months, we've had at least one outage. I know it's at Miranda House. So that actually is helpful to some degree. So it really allows us to test our plans in relation to that. So it is something that's looked at regularly through the EBRR routes.
Thanks very much.
Happy with that, Mike?
If I could just add to that one point, you'll notice from the report we are putting a backup generator at Miranda House because the outage was not of our doing, it was the whole of Hull Anliber Road that dropped its power, which affected us. So we've now got a backup generator tendered in.
Thank you for that. Francis.
Thanks, Chair, and thanks, Michelle, for another really detailed report. And I'd like to just reiterate what everybody said about, despite everything that's going on with COVID, to win the amount of awards we've done is excellent. I just wanted to understand a little bit more. It's the first time I've really come across it, and it's a great story. Under Lynn's section, the positive assets individual placement support, which seems a really good service, and there are 2 case studies in there, and just to understand a little bit more about that because it seems really good. I know people waiting for jobs; it can be really stressful and set mental health issues off.
So I think what we're seeing, obviously, is that prominence, Francis, of health inequalities related to opportunities around employment. And obviously, I think for me, the board understands that that's really important, particularly for our mental health service users. So the fact that we've actually got dedicated support in place to support people who need it, both to access employment and employment, particularly in relation to IPS, is for paid substantive roles. But also the service also supports people who are already in employment to maintain their employment through an episode of acute mental ill health. So key to the service obviously is really growing the connections networks with employers as well. Now, obviously that was disrupted a little bit through COVID, but I think the service is really sort of, really focused on that right now. So I think it's really important as well that the board are aware of that, we really keep that focus in mind. So we were fortunate that we did have a very small service before we secured the income for the IPS service. So we did have a basis to work from. The service also connects really well with our other sort of key services, such as the Recovery College, for example. And we're actually planning to run some pre-employment support programs through that route as well. So I think with the lived experience, the peer support workers that we've already heard tell of today, I think we've really got now sort of fundamental basis to grow from that whole approach around recovery and, really sort of reducing reliance on the medicalisation, I guess, of mental health, which is important, but we need to get this piece right too. So thanks for raising it.
Thanks.
Yeah, there's some really good case studies there. And do we get support from Job Centre Plus for this as well? Are they one of the partners we work with?
There was certainly one of our key partners, Caroline, yes. And I think that's where originally this scheme nationally was connected into around that really important relationship.
Thank you. Francis, did you have another question?
Oh, that's it, thank you.
Okay, Hanif.
Yeah, thank you. Thank you for the report, Michelle. I think this may be one for Steve. I believe this is the second or third consecutive report that there's been some reference made around the problematic issue of recruitment in particular areas. I'm not sure if the international recruitment fair that's alluded to in the report has existed at all. And I know we've got the risk management strategy now due to be presented in January, but is it getting to a stage now where it actually needs to be flagged further up the chain in terms of its potential impact moving forward?
So it is one of our highest risks, Hanny. So it is logged on the risk register. It's something that we talk about in workforce and an OD committee work that we're doing alongside that. We can, whether we want to pick up in the work that we talked about in workforce and OD when we get to the assurance report around there, maybe talking about some of the detail in that, Hanny. But absolutely, it's our, I think, if not looking across, if not our highest risk, our second highest risk that we've got scored for the trust at the moment.
Did you want to add anything to that, Hanif?
Well, just really flagging it up for us as a board, I think, in terms of probably giving it more prominence moving forward, as I say, as we get into the new year. I know we've had brief discussions on it, as I say, on at least two, if not three occasions, but it clearly seems to be apparent that we need to give it greater focus.
Yeah, thanks for that, Hanif. And of course, a lot of the plans and ideas that are being developed are contingent, as we were talking the other day, Lynn, in terms of assessments for children in terms of autism, need the staff. Absolutely. Michelle, I think you wanted to add
Yeah, no, I just
something
wanted to say a good question, but obviously, yes, it is one of our, if not the highest risk, and has been for a while. The Workforce Committee actually really major on this all the time in relationship to what we're doing, how we're doing it, if there's any way we can facilitate things better. The international recruitment's been really positive, so I thank the international recruitment team that we're getting some really positive feedback back. We've got our next cohort that we're looking at. And actually, when we look at our figures from an organisational point of view, we're actually not an outlier. We're actually doing really well at recruitment and retention. But obviously, the whole of the NHS and social care is really struggling from a workforce point of view. We are growing our own as well. So we've got that longer term strategy. So we're trying to do it from both ends, really, that shorter term piece, which is how we fill the post now in an innovative, creative but patient safety, patient focused way, and then also how we get to that future piece, which is how we grow and develop our own, whilst being an anchor organisation as well. But there's lots and lots of work which I'm happy to share. I mean, obviously the Workforce Committee do the majority of that, but it is a really positive discussion that we have there.
Dean, did you want to add anything to that?
No, only to reiterate.
You're chair of that committee.
Just to reiterate what Michelle was saying, really, in terms of the focus that we have on it in the Workforce and OD Committee. So I suppose the two big things we look at is always looking at our pipeline, and then always looking at the staff we've got in the organisation, their health and well-being, and whether they're giving of their best, and we're supporting them to do that. But I can touch on it a little bit when we do the assurance report as well, if that helps.
Thanks, Dean. That'd be great. Any other questions, John?
Just to say, I think it almost passes by in the Chief Exec report is the success of IT and clinical systems in the Digital Aspirant Plus programme. That was a hugely competitive national programme. To being successful in that is a huge boost for us, because to go back to Mike's point about the staff survey, our organisation and many others, one of the things people get frustrated with is their perception of their electronic patient record and IT in general. And this being successful in this programme is going to give a significant investment in the short term to work with our clinical colleagues and others, including patients, to think about what our system needs to look like going forward, so that's fit for purpose, and then, if necessary, access to future capital from the centre. So that's a really big win for us. As you said, we did, from terms of our staff, it's a really big win for us. So I have to say, well done to Pete and his team. He's, as ever, very modest about this sort of stuff. But that's one of the bigger coups I think we pulled off in the last few months.
Yeah. Thanks for that, John. Thank you, Dean.
Yeah, just picking up on the zero carbon, Pete, and the COP26. All the UK health authorities have agreed to this zero carbon, and we're putting it through a sort of green plan. And it talks about going through the normal governance procedures. I just wonder if there's an opportunity for us to engage things like the youth forum, patients and users, as something to really sort of, big up our ambitions around it, really, to hold us to account. And it seems a really important issue for us to sort of get a focus on. It may not seem like it in the context of everything else that's going on in the world at the moment, but just that idea that it could be something we could really show our sort of ambition in this area.
Absolutely. And also it saves us money as a trust if you can get those energy bills down. Pete,
Yeah, I think it's a great suggestion. I'll take it back to the team and I'll link in with Michelle Hughes in terms of those forums out there that we can engage in doing. It's a great idea.
Great, thank you. Yeah, good.
Great. Okay, if there's no other questions looking around the room, no. Thank you, Michelle and directors, for the report. We move on to publications highlights report. Over to you, Michelle.
So can we just approve the policies?
Oh,
Yeah,
sorry.
we need to ratify the policies, Chair.
The two that I alluded to, the document control policy and the tissue viability policy.
Oh, yes. Okay.
Chair, can I just check, have we seen the document control policy? Has that been through a committee, or is it, I apologise if I missed it in the minutes,
No, because we're the committee for the document control policy.
but if we're ratifying it, do we need to see it?
We can, yeah, it's a good, I'm looking at Michelle, it's just a good point, actually. Yeah, we can circulate.
I can circulate after the meeting. As Michelle alluded to earlier, in EMT, there was a discussion about, particularly with committees moving to quarterly, the timeframe of getting the churn of committees through. So the key change is just the approving committee, which EMT will be for all policies.
That's fine.
The assurance role of committees, it will be unchanged, and you will receive at least annually a report from the database of policies for those policies under your committees. So under the rules, if it's this type of change, the approving committee can do it, but you raise a valid point for information, we'll share it through email to the whole of the board. But I take it that doesn't stop us ratifying it today, and we can proceed.
Well, I just think if we're asked to ratify something, that we ought to see it. So if it's not been through a committee, and by the way, I'm very supportive of the idea of exec teams sort of doing this, but I think for the ones that haven't been through a committee, particularly for the first time, that maybe it's just that they're attached, that we can just have a look and then we can raise if there's any sort of issues.
Yeah,
Are we okay if we ratify it subject, if we
Subject to
circulate
that
it?
circulation.
And if there's any major issues, we'll pick it up in the January board. Is that okay, Dean?
Fine by me, yeah.
And just to clarify,
Everybody
EMT was-
happy with that suggestion? And then moving forward, if it comes back, something like that comes back again, just make sure we've seen.
It's a
That
good point, because
document.
we as an actual board, we don't have many committees that we own, as it were, but we do one. This was, it's a good point, Dean, but we'll circulate it, we'll ratify it subject to that, and if there's anything, we'll pick it up in the January board.
Okay. With that discussion, are people happy to ratify those policies? Okay, thank you very much. Moving on then to publications and highlights report.
Thank you, Chair. This is the usual report about the publications and policies that have come in from the centre, just to draw your attention to where they're being dealt with within the organisation or wider. We've already alluded to a couple of them, and the transactional guidance will obviously go to the Finance and Investment Committee at a later date in relationship to the changes for that. But it's there for information, Chair, and any questions.
Any questions? No? Then are people happy to receive and note that report? Yes. We'll move on then to the performance report. And we have Pete.
Thank you, Chair. So this is the usual performance report, which takes us to the end of October. You'll see from the front sheet, we've included commentary for those indicators that fall outside normal variation. I think before we move to questions, as we've done for the last few boards, I think it's usually quite helpful for them to give a quick update on waiting times, and then we open up the floor to questions, if we may, Chair.
Thank you, Pete. Lynn?
Yes, thank you. So I guess the key headlines are that we are continuing to see improvement in the CAMS autism spectrum diagnosis pathway, which is good and positive, but we have seen an overall increase, unfortunately, in the number waiting for over 52 weeks in other areas. As the front sheet describes, the main area that's contributing to that is the same as last month, is increase in CAMS waiting times. That's contributed to because the demand for CAMS is continuing to be very high overall, but the most significant area is the ADHD element of that as well. So we are focused very much on that. Caroline, you've always talked about the presentation to the governors yesterday, which covered both ASD and autism. So we've got waiting time approaches, measures in place to address that. But fundamentally, what we talked about yesterday, which is also referenced in the narrative here, is the change that will start to come into effect in January of a very different neurodiversity pathway for both autism and ADHD for CAMS going forward. That fundamentally should give us the systemic transformational change. It will take time for that service to bed in, undoubtedly, but adding children just to waiting lists to be the only option is the fundamental change that will come about with that service and its new model and approach. The other areas that we're focused on at the moment is we did see a suppression of referrals for memory assessment through the pandemic. Those have risen again now. It is what we anticipated. So again, we've got focused, targeted work across both Hull and East Riding to address those areas at the moment. So I can assure the board that the focus remains very robust, very high. There are some elements where staff availability and vacancies are contributing to some of those pressures, but again, we're doing our utmost to plan to address those. So I'm happy to take any questions in relation to waiting
Thanks,
times.
Pete. Thanks. Francis.
Not so much a question. I know we discussed this a lot at Workforce, but just as a board to acknowledge the fact that sickness is slowly but steadily climbing at a time when we've already discussed winter and winter plans and winter pressures and the pressure on staff and everything that's going with it, and then feeding into what Lynn's just said in terms of waiting lists, etc. So it's just being aware of that. You know, there's not a lot we can do about people being sick. They are sick, and there's a lot of pressure being on. But I think as a board, we just need to be aware of the fact that it's been climbing steadily for the last 2 or 3 months, and is concerning. So I'm not asking a question, just flagging it.
Yes.
Do we know how much in terms of the sickness absenteeism is stress related at all? Do we have any breakdown around that?
Our stress and anxiety related sickness is usually around sort of the 42-43% of all sickness.
Okay.
That's a usual, Caroline. I'd have to give you the exact figure to look at it, but it's around about 40 to 45%.
Okay, thank you.
Sure. It's
Dean.
probably worth highlighting in terms of absence for staff as well, that the NHS is subject to different rules in terms of isolation, household contacts, etc., that will have an impact upon that. And I think what we're seeing across the NHS is that when infection rates go up, we tend to see absence in the NHS sort of go up as well, largely because of the rules that we have around infection control and national policies as well as local policies on that.
Yeah, thank you for that, Dean. Any other questions, Peter?
Yeah, I think continuing on the theme of winter pressures and we talked about sickness, which is important. The other one that I'll maybe picked up on, and it is mentioned in the report as well at the front, is delayed transfers of care, which has crept up, I think, with winter coming along. And I do understand that it's not always within our control. In fact, it won't be within our case. Sometimes it's delays with local authorities that we have delays transfers of care. But I just wondered, since this report was done, has there been any improvement in that position? And what is the outlook now that we're getting sort of late November into December on freeing up some of these beds which are being used by people who actually should be transferred back into the community or into another environment?
Lynn?
Yeah, I'll certainly start. Unfortunately, Peter, I don't think the position has improved. What we are seeing, and I think I've reported it here before, is some delays, particularly for the very complex group of service users. So we're not seeing particular rise in short delays. In fact, I think our systems and processes that we put in place last winter are still standing us in very good stead around those. But these are complex mental health and complex learning disability service users particularly. So again, you know, that they are, because we're waiting for very often very bespoke placements. So they are in train, but for example, we've got at least 2 delays that are waiting for purpose-built accommodation because of the delays around that industry as well. Then that's contributing to not only are the sort of pressures around sort of lack of availability because of the staffing pressures in local authorities, but new builds are being nationally as well. So it's a combination of factors that are making this a very complex problem at the moment. So we are raising that obviously at very senior level with our system partners. It's again in terms of risks, very high in terms of system risks at the minute. So a lot of collaborative working taking place between ourselves and local authorities and the commissioners to really look at what more we can do around this. But again, I think unfortunately it's a complex situation impacted from COVID and other system pressures.
Thank you.
Any other questions on this, Michelle?
Yeah, just on that, just to pick up from Lynn, one of the things that we're trying to do as a system is try to be a bit more proactive in relationship to some of these individual patients, because we know where they are in the system, because they've been known to us, not just us as an organisation, but the system for a long time. So we just need to be a lot more proactive. So we're doing a lot of work across the partnerships just so that we can try and prevent people being delayed, because obviously we don't want that to happen for anybody's sake. So we're actually on with that, Peter, for the longer term.
Okay. Francis?
Yeah, just a second question. I was just looking at the out of area placements, which good news is it's starting to drop, and we've discussed it a lot. And it's not a question really about us, it's a question of what's the national picture, because obviously we're having to place a lot of people out of area. Yeah. I would have expected, with what's going on with the issues we've got with mental health, that every area is struggling at the moment. So I just wondered what the national picture was in terms of beds and our ability to access out of area when we're short.
We're probably about mid-pack at the moment. We were, excuse me, at the positive end, but when you match our, and obviously Lynn will be able to verify this, but when you match our out of areas to our bed reductions because of the COVID restrictions, they actually do match. Now, obviously, Maester coming online, that will help and really be beneficial, because obviously put some more beds in there. But across the system, we're in the pack. So we're not the highest, but we're not the lowest either. And across nationally, we're probably more towards the lower end. And again, that's because of the COVID restrictions, because obviously we've had to take some beds out of the system. And don't forget, we've got quite a low bed stock anyway, as an area, because I think a couple of years ago, we were talking about our actual processes around short stays, quick discharges, but safe discharges, low readmission rates, reduction in number of beds, good occupancy. And actually we were cited as one of the exemplar sites for that flow. It's still good, but obviously because we started off with a low bed base, taking a few out, it puts pressure on. And then obviously there's the issue around the acuity and beds around the system. We are looking more across the bed capacity across Humber, Coast and Vale. But as you know, some of our partner organisations have actually closed whole units down, which is making it even worse as well. So I think to answer your question, we're not an outlier. We're in mid-pack from a regional point of view, and from a lower pack from a national point of view. We have made a commitment, though, to get back to no out of areas by the end of the year, not the calendar year, the end of the financial year. Which will be a push, but we are, and with my ICS hat on, we will have to deliver that.
Thank you, Michelle. John?
Area challenge. It's a really important one to continuously talk about. I would just like to reflect back that we also think about the safety of our current wards in terms of infection control, and how one of the tensions of having out of area beds is that you can keep your patients and your staff safe on wards. So we haven't had many COVID outbreaks. Fortunately, we haven't had associated mortality on our inpatient settings related to COVID, unlike other places. So I think there's a suite of metrics that we need to think about when we think about out of areas. That's not to dismiss the risk associated with out of area placements and the inconvenience and the poor experience for patients and service users and the families. We absolutely get that. But the other thing we are mindful of in the middle of a pandemic is making sure that people are around from a COVID point of view to tell the story today, tomorrow and the next day. And I'm not always sure that that tension is understood at a wider level, particularly when you just focus on one metric.
Yeah, I'm not criticising that. It's a bit like every country in the world is borrowing money because of COVID. Well, who are they all borrowing it from? Because if they're all borrowing, who's lending it? And it's the same with beds. If everybody is having out of area, who's providing them? Because if everybody's doing it, there must be a shortage somewhere. So I'm not coming at it as a criticism from this. It's just an understanding of the national number of beds. If we've got rising number of cases, has we nationally got the capacity to actually deal with it?
Yeah.
Yeah, it's a it's a good question because, and actually nationally, the picture for children and young people is absolutely severe. There is just, we know that there is a real issue because of the rise in acuity and the actual pressures and the numbers coming through. So it's a really good question, and we're constantly trying to plot it and work across systems. But it's a really good point.
Okay. Unless there's any other questions, I think oh, sorry, Dean.
So it was just a quick one, Chair, just recognising the important role that governors have around this. And we had a really good session yesterday with the governors around waiting list and sort of sharing that sort of data with them. And we know that they're there to sort of hold us to account as a board in terms of how we're doing it. And I thought Lynn gave an excellent presentation yesterday. I just wondered if it was worth reflecting in this meeting that we've done that.
Yes.
And whether there's anything, Lynn, that you'd sort of want to bring into this meeting about the discussion that took place and how we were responding to some of those areas.
Yeah, no, I appreciated the opportunity actually to talk to the governors yesterday. No surprise, just as here, that they're concerned for the right reasons, which obviously is around, access to the service for children, young people and their families and the impact of that. So it was really, I think, helpful. It was good to have Justine Rook, for the manager of that division, to talk really about the future as well, that whilst we're operating in a particular way at the moment for the reasons I've said earlier. So it might be helpful to share a bit more detail around that service model with the board, having shared some of it with the governors yesterday.
Yeah, I mean, I think that I think we had a 5-page presentation, which was, summed it up pretty well. And it did include, I think, at least 2 graphs in it too.
Mm-hmm.
And that might be worth making sure that's circulated amongst the board to have a look at that too. But I think what was really interesting, I think maybe you'd agree, Dean, was that, everybody is concerned about, important to say, that's the assessment, that's our part of the process, but all the things that actually contribute to the numbers before we even see people. And I think what was really valuable from our discussion yesterday was knowing that it wasn't that those young people didn't necessarily get some support, whatever stage they're on that journey. And that's really important. But I think what we agreed at the governors yesterday, as well as the sort of obviously the monthly reports we get and the stats to keep us alert to the situation, there's changes happening to the services in the new year, and agreed with the governors that we'd have a similar event in 6 months' time to see whether things are really happening as a result of the changes being made. And that might be something we might want to come back to at the board as well, for our benefit too, if that's all right with you, Lynn and Justine. Great. Thanks for raising that, Dean, because it was very productive, I thought, yesterday. Thank you. So I think we can take a little break for a comfort break here. So we're going to stop streaming now and welcome you back in 15 minutes. Welcome back. I'm Caroline Flint, Trust Chair for Humber, and we're here at our board meeting, and we're recommencing with the finance report from Pete Beckwith.
Thank you, Chair. So this is the finance report as at the end of October. As always, I think I should remind the board that we are continuing in a block funding arrangement, but as a bit of an unusual one for this month, when we wrote the report, we had no ICS planning target for the second half of the year due to the timing of the planning guidance that came out. You'll notice from the report that at month 7, we recorded a minor operational deficit, but actually our year-to-date position was consistent with our planning target for the first half of the year, which was a £315,000 operational surplus. You will see from the report that in October, we invoiced Hull City Council for the first tranche of the Section 75 monies, which is supporting the Yorkshire and Humber Care record. This is treated as a revenue grant, so that falls outside of our control total, but does increase our ledger surplus position. And we've discussed that with the auditors at length about the correct treatment so as to avoid anything at the end of the financial year. So actually, we have a 1.4 million reported surplus on our ledger. A couple of the key points, and then I'll open up for questions. Our year-to-date COVID transactions total just over 4.2 million, which is consistent with our allocation. We noticed our cash has increased in month, and that's primarily the timing difference between the lead provider income since we went live on the 1st of October and the timing predominantly for the independent sector provider payments. And our agency spend does remain high, but obviously we have plans to review that through Finance and Investment Committee. And I'll stop there, Chair, and happy to take any questions.
Thanks very much, Pete. Any questions? Mike.
Thanks, and apologies, Peter, and then I've asked this before, and it's the £610,000 underspend in mental health services. We are overspent on agency, and if we were fully staffed on mental health services, and we wouldn't have a £610,000 underspend, we'd have an even higher overspend on agency. Now, I'm sure some of that is to do with problems of recruiting staff, and you can't recruit staff that don't exist. However, if we're not spending £87,000 a month at month 7, X number of people, say 4 people, I don't know. And I'm just wondering how we could be assured as a board that we're not compromising our care, because we're obviously short-staffed and money won't help.
Do you want to, I mean, I guess what I would say from a finance perspective, and I'll let Lynn cover on the operational, Mike, is when we set the plan for the year, we fully funded all the investments we had for areas such as perinatal, community mental health teams, mental health support teams in schools. There has been some recruitment challenges in those areas, which predominantly we're in a better position now than we were at the beginning of the year. So the run rate will slow down in those areas in terms of the staffing underspend. The only potential thing to consider is we have got some non-recurrent investment for winter monies, which will require staff and resource. So there's always the danger, isn't there, that there's only a finite pot of staff out there. And when we invest in one area, we often, it's my name, isn't it? But we rob Peter to pay Paul. So I don't know if you want to add anything to that, Lynn.
Yeah, just to add to that, and I think probably, obviously the safer staffing element of our areas is under constant review by Hilary and I, and for the reasons that I've discussed earlier, we're paying very close attention to that at the moment. I think, as Pete says, there is some expected slippage in there as well, because new schemes have come on stream this year. When we are putting forward proposals for winter schemes, for example, obviously we do take into consideration staff availability in relation to those. So very often they are actually predicated on non-registered workforce, because they are easier to recruit, or indeed working in collaboration with the VCSE, our third sector partners, which I think we're doing increasingly successfully around some of those areas as well. However, we are looking at other measures as well. So, for example, we don't have tremendous difficulty recruiting registered healthcare assistants, for example. So really looking at ways in which we can increase the numbers that we have in substantive roles and utilise those even more flexibly than we do at the moment. So I can assure you there are a number of approaches that we're putting in place to try and address that. However, there is an underlying pressure around our registered and some of the hard to recruit to posts, obviously, which Steve is pursuing through his workarounds addressing some of those vacancies.
I thank you for that, and I also thank you for the work that you've done in the past in terms of HCAs and in terms of changing job roles to enrich the role of HCAs, and that the safer staffing doesn't worry me. What does worry me is the public perception that we've got declining performance, yet we've still got vacancies, and it may be in terms of the narrative of reporting that we need to alter, but I just wanted to dispel that perception that we're somehow trying to save money here by vacancies, or we're not doing our job properly, and I'm very much assured. Thank you.
Thanks for that, Mike. And I think it's a point well made. It's not that we wouldn't want to be able to recruit using the resources we've got. The problem is finding the staff. Thank you, Francis.
A couple of points, one for clarity and a couple of questions. First of all, picking up on BRS, Pete, just so that people are aware, that obviously is the corporate one that's showing non-achievement, but there is BRS being achieved elsewhere, isn't it?
Absolutely. As we see it, Finance Committee normally in the insurance slippage on there, but it's generally on target.
Yeah, so it's just so that people understand what's going on in there. The two questions were one around corporate services, which have underspent by 888,000, so just a little bit more understanding on that. And the other one is on the statement of finance. Again, there's the big swing in intangible assets, and maybe a little bit more explanation for people on that.
So finance technical, Francis, corporate services will be predominantly influenced by finance technical, where trust contingency sits, and I could do a post-meeting note to break that variance if that would be helpful for members of the board.
I think it's just useful for other who aren't at thick to understand.
Yeah.
And the movement in intangible assets relates to the capitalisation of the Yorkshire and Humber care record and the treatment of it, whereas it previously been an asset under construction.
Thanks for that, Pete. And if we could get that sort of note clarifying that for people, that'd be really helpful. Peter?
Okay, thanks. Thanks, Chair. Just a couple from me, Pete, if you could. Just on agency spend, I know what Mike says, but the actual spend in the month is well down. It's nearly 280,000 down on September, which on the face of it is good. I just wonder if you could explain in particular the reduction in consultant agency spend of 200,000, and whether the October figure is more like what the norm will be for the rest of the year, if you had a crystal ball. And the other thing, which I think is just an observation really, in the finance report, it would be useful perhaps for next time to have a little table on capital expenditure, because I do, we have had some capital schemes and we've got some more coming up. But my understanding is that it's quite back-end loaded, and I think the board perhaps needs a bit more sight on that.
Yep. So the easy one, Peter, capital expenditure, more than happy for that to be in next month's report. And you're absolutely right. It is the hockey stick effect that we refer to it in terms of how capital spend generally flows in the NHS. On the consultant spend, I would guess that's reflective of success in recruitment, but obviously I don't have the detail underneath that with me today. I mean, again, I'm happy to share that outside of the meeting, but I know from feedback from John and Lynn predominantly, we have had some success recently in secure services.
I think it particularly does relate to secure services. So, and I think to note that secure services are overall in an underspent position. If you go back a year, that's quite an improvement, and it is to do with the substantive recruitment of consultants.
It's good to hear. Good to hear. Anybody else? No? Okay. Thank you, Pete. The board's agreed to receive and note that report. We'll move on to the Assurance Committee reports, item number 11. And Peter, you're introducing the Humber Coast and Vale Specialised Mental Health, Learning Disability and Autism Provider Collaborative Committee Assurance Report of the 28th of October.
Rather you than me on that one, Chair, but thank you. I mean, 28th of October, so that was just 4 weeks into after the go live date. So really well done to the team on achieving go live for these work streams, which is really important. And since the meeting, as the Leeds York Partnership Foundation Trust have signed it at their October board meeting, which is good news. So in the meeting itself, obviously we went through the main purpose of it. I think this time was we had a new member of staff, Gareth Flanders, came along and went through quality assurance aspects. and talked about how he was developing a quality dashboard, how serious incidents were going to be reported and dealt with. So we spent quite a lot of time talking about that, as well as the various work streams from the three groups, and how out of area activity was being brought back within Humber, Coast and Vale, and the successes there, which are detailed, some of which are detailed within the report. We also approved new terms of reference, so they should have been annexed. I think we'll have to do that next time. But it's basically to include Associate Non-Executive Director Hanif on the committee, and also to change the quorum to 3. I think it was a larger number before, so that we're more likely to be quorate. So 3 on the quoracy, and include Hanif on the committee.
Thanks, Peter. Are there any questions or points? Mike?
Yes, I'm very pleased to see the Learning Disability and Autism Pathway Panel being established. I reported at a previous meeting held in this room that I saw a bit of a disconnect between what was being done at Place in terms of our autism and neurodiversity, and how much the ICS was doing, and that the establishment of that panel seems to tie in really, really well with the tremendous work we're doing here, and fits it into its strategic context. So thank you.
Yeah,
Thanks.
Mike.
Thanks, Mike. Anybody else? Michelle?
Just a quickie, just to say thank you again to the team for progressing this agenda, and for Peter for chairing the collaborative committee, because we've done well over the last 6-7 months to get it over the line, and obviously now we've got all partner signatures. I think that's a really impressive position. I think it's really good to see the quality piece, because obviously there's been a couple of reports published around not just about provider quality, but also from a commissioning point of view as well. And I think it's important that we remember of our responsibilities, duties and obligations to our service users and their families in relation to commissioning services as well. So I know the committee will pick that up going forward, and perhaps as a board, we can just have a bit more of an assurance as that develops and progresses over the next few months.
Yeah, thanks, Michelle. Point. Anybody else? Okay, receive and note that report. Yes, thank you. We move on then. You're up again, Peter. Charitable Funds Assurance Report, please.
Okay, thank you, Chair. So we had a meeting last week. Perhaps, the report's here, I won't go through all of it, but perhaps a couple of things. The Whitby appeal, we're trying to raise 85,000. We're nearly halfway there. So there was 39,791. Another couple of thousand has come in since then. And just to remind board members that you may have seen it within Global, there was a bricks or a chance to buy bricks for the garden brick. So if anybody would like to invest in a brick, then that would be very nicely received, I'm sure. But the momentum is there for Whitby. I'm sure that with that part of the fundraising and other initiatives, that they will get to that 85,000. General charity giving is quite low, so we had a discussion about that, and Hey Smile are going to produce a paper, I think by the middle of January, just to sort of revigorate some of their ideas about how we could actually get some fundraising campaigns and some of the smaller gains sort of into charitable donations for our trust. So I'm working perhaps a bit more closely with the ops team. So that will come through in January. So we'll see how that one develops. And once that comes through, I imagine we'll probably have just a small meeting just to discuss that paper, because you will have noticed at last meeting as well that the general donations are lower than they have been for a while. I mean, that's to some extent a blip because of COVID, and it's just it's difficult. But I think we just need a little bit more rigor behind that now that we're coming slightly post COVID, and we can do that with the team that we've got in place. So those are probably the main things.
Thanks, Peter, and thanks for the info on the brick. When I was reading that, I was thinking about, yes, I think I should get a brick. done. And welcome anybody else and anybody watching. If you want to get a brick to raise some funds, let us know. And I think, Michelle, you were talking about what you might be doing for your charity event.
Yes, obviously I do a chief exec challenge every year. Obviously I missed it last year with it being in the height of the pandemic, and this year we were looking to do a couple of things, but I'll probably definitely do something in January, maybe something around a cycle ride or something to get everybody back into health and fitness. So watch this space, but I will be coming to people for huge amounts of money as usual, alongside our sponsors as well. I think up to now I've got about 18,000 all together for staff and our patients' charities.
There
You could cycle around every site we've got.
I'll probably do it stationary, I think.
I'll be the pit stop. You know, John.
I am looking for, because I'll probably do 2 next year, because obviously with Mrs. So I am looking for suggestions and ideas, reasonable suggestions and ideas for later on in the year. So if you please do feel free to contact either Christina at Health Stars or myself. At the moment, I think we've got abseiling and things like that, but let us know, because the idea is to do something that's sustainable for a long period of time. So.
And as long as it doesn't involve a great height, I might join you in all of those endeavours. John.
So, Peter, just back to your report. You've mentioned the fact that fundraising is more difficult, and you think that's just a blip. I'm just wondering, is what lies behind that potential assumption, or is the fact that fundraising has gone down just a recognition of a harsher economic reality that we're now living in, number one? And is there any soft intelligence from what other healthcare organisations are finding with regard to their fundraising activity of having that blip?
My own take on it is that we're not alone on it. I think part of it is obviously COVID related. The lack of personal contact, I think, is an issue, and the lack of sort of being able to get together at party nights and bingo and these sort of things which sort of have been put in abeyance. So I think that's part of it. And as we come out of COVID, hopefully more of these events will be able to be planned in the future, John. So that's my take on it. And also, you know, we had some success with some large capital projects, Inspire being the big one, and to some extent Whitby, which we're still working on. But there's things like Maester Lodge that we talked about earlier, and you know, is a little bit of sparkle that we can add to that, to you know, from a charitable funds perspective, just to add a little bit to that scheme with some of the funds that we've already got, or new funds. So there are some initiatives that I think we need to you know, discuss and promote. But I do think we're not alone. You know, my understanding from talking to the people at Hey Smile who deal with this more is that we're not alone in this situation. So, you know, let's hope we can, you know, find a very positive way through it.
Mike, then Hanif.
Declaring an interest as chair of the Rotherham Foundation Trust Charitable Funds Committee, we're not alone. But I would say a couple of things. The first one is exactly as you said, that the £1,000 from a karaoke night has just not been happening, and then they really mount up. But the second thing that I would say is that we have been well supported as a trust by NHS Charities Together, and we have had income this year that's probably concomitant with previous years, and have taken the decision, or through your committee taken the decision, to support the staff, which has been really, really important. So I'm not knocking we need to raise more, but we shouldn't beat ourselves up either, because we've had income and we've spent it in the proper way, which has been in support of our staff at this moment in time. Now we just have to go back into the different world, because it always will be different, and think about different ways to fundraise in the future.
Yeah. I mean, it is those other events like the karaoke nights and things like this. And it's also, you know, all the other, you know, people buy a ticket to come along, they buy a ticket, take part, they buy a ticket for the raffle. It's all those things that sort of add up for a good night out to make some money at the end of the day. Hanif.
Yeah, just echoing what Mike said there. I mean, at first glance, some of those figures on paper do look disappointing, but that is symptomatic of the not-for-profit sector as a whole and the impact of COVID. What we did agree at the meeting last week was that we would have, if you like, to a degree, greater input into the work of Smiles and Andy, and just see if we could be supportive through a degree of, I don't know if capacity building is the right word, but in the vein of, as I say, trying to be helpful to see what else might be possible. So just as an example, just really in terms of how that sector is going to change and is already beginning to change in a post-COVID world, is incorporating things like a digital fundraising plan within the overall strategy. So while those traditional increasingly not-for-profit sectors now very much changing in terms of how it derives its income. So a little bit of watch this space and seeing what we can do just to work with Andy and the team there, just to get it in a bit of a better place than it currently is, maybe.
Thanks, Annie, for that. Okay.
Can I
Oh, John.
So I think there's two sources of income, isn't there? The general public, and I would reiterate my view about the harsh fiscal climate we're living in. People don't have that disposable income. Any thoughts on what the major benefactor opportunities might look like? Has the committee discussed that? And where do they, in terms of some of our major schemes coming up, how does the land lie look in terms of that? Because that's the other source of charitable funds, major benefactors and corporate.
Steve,
Yeah, I've not been here long enough to have that detailed insight at the moment.
Steve, can you? Yeah,
Sorry.
putting Annie for the spot for that.
Yeah, John was.
Sorry, I wasn't aimed to it.
I didn't know where the question was directed.
Steve, would you?
Was the question
So
directed?
just say the major benefactors as an access to sort of charitable funds. Does the committee have a view on how the land lies on that at the moment?
I think the committee discussed that. I think there's, I think if Andy was here, he would say understanding what we're asking them to fund would be important. So us having that kind of strategic direction to understand where we would be going to ask people to support John. So I think Andy would talk about that and us giving that clarity, and that was something that the committee discussed. I think there are people out there who want to support things. We need to be clear about what we want them to support.
Okay.
Yeah, that's an interesting point. Francis.
I'll just put a counter to that. If you look at what's happened over the last couple of weeks, it's more money than ever been put into children in need. We've just had an MND yesterday, which raised a huge amount of money. People have got the money and are willing to give it. It's finding a different way to access it to do that. Yeah. And joking apart, when I said, cycle around all of the various hospitals, it's that kind of thing when you're out and people can see, and I'm not suggesting Michelle, but if you could get a celebrity or a star to support you, that seems to be the way to go at the moment in terms of raising cash. So I would put the counter. I don't think there's a shortage of money. It's how we access that money.
Do you mean like the winner of a celebrity mastermind program could head it?
Get me on Pointless.
Yeah.
Or House of Games. No promo for BBC quizzes there, but anyway,
Yeah.
Michelle.
Just one time. I mean, the committee has had a long conversation about fundraising and how we do fundraising, and we maybe have a conversation about that out with. But we have had a lot of conversations, whether it's about donations, benefactors, whether we've got projects or not in relationship. And I think Francis is right. There is money out there. I think some of us are trustees elsewhere, and we've had a really successful year because it's that innovative and different ways of doing things, with a digital platform or whatever. So we've had a long conversation about that and how we go forward in relationship to creating some funding and access to funding and what have you. So yes, it's all been discussed at the Charitable Funds Committee and in quite a lot of detail as well.
Okay, that was a useful discussion. I mean, I think there's, fundraising is about having different opportunities, something that is identified and willing to put their hands in the pocket quite substantially. And then it's the volume of people you get who might only be able to put a smaller amount up in their pocket to support something. But fundamentally, they want to know about it and they want to know where their money's going. And that's fair enough. And I'm sure we've got enough proposals that could tick all those boxes. But yeah, thanks for that report. And I know the committee is working hard on those different areas. So thank you for that. So received and noted that. We move on to Quality Committee Assurance Report and their minutes. And Mike, over to you.
Thank you. And this is my first meeting as interim chair following the retirement of Mike Cup. And I'm being well supported by Hilary and by Sue Hutchcroft as committee secretary, who are helping me. I've now got two committees to look after. Our concentration in this meeting was in safety in two respects. First of all, we had Colette Conway leading with Rosie O'Connell, our new safeguarding lead, talking about the general issue of patient safety and approving our patient safety report. We looked in detail at the Corston Park Private Hospital and the care given to Joanna, John and Ben and the implications for our trust. And I certainly felt assured as chair that safety runs throughout the organisation, which brings me on to my next point, which is the non-clinical safety report. We have some unsung heroes in our organisations, in our estates team, places like that. And these are the people who put in place processes so that the fire service doesn't have to get called out every time a patient sets fire to a litter bin or something like that. I'm not being prejudicial there, but we do have these incidents that take place. We received an excellent report from our lead on that service. The next one I'd just like to highlight, because the rest is in the report, is the recruitment of international nurses. We're assured that these are ethically sourced, so we're not stealing nurses from other countries. There's actually oversupply. They're being integrated really well into the organisation and helping with our shortages. We also talked about the role of the professional nurse advocates. And sorry, just going back on the patient safety, the new role of patient safety specialist. So with that and the report taken as read, Hilary, do you want to highlight anything else?
Yeah, I should say there was a big theme going through, wasn't there? And we always talk about patient safety, it's been even more so at this quality committee with the annual report going and the presentation from Colette as one of the patient safety specialists. The committee did suggest that we had a staff story about patient safety for the board, and we scheduled that for February. And we also discussed, didn't we, about having one of the board timeouts, a bit of a focus on patient safety, particularly with new non-executives as well. So we can run through our approach, obviously, to patient safety, but the national changing picture as well, and have a really good discussion at board about how we take that forward. So hopefully that will get planned in for next year. I have obviously raised that with Michelle.
Thanks, Mike. Thanks, Hilary. And thanks to all the non-executive directors who've taken on additional responsibilities, either chairing or attending another committee whilst we fill the other vacancies for non-executive directors. Thank you all for that. Any questions or comments to the report? No? Okay. Thank you very much, Mike. That's received and noted. We'll move on to the Workforce and Organisational Development Committee Assurance Report. Dean.
Thanks very much, Chair. And just reflecting, I suppose, on the conversation we had earlier just about vacancies. And I think this assurance report gives that sort of sense, really, that what we're looking at here is the vacancies that we've got, our pipeline to be filling those. And then when we've got people in work, how we can support and look after them, ensure they're valued so they can deliver the best possible care. And hopefully people will see that in there. Over a period of time, the committee has received increasing sort of assurance about the work that's going on around workforce. So we've been gearing back on the amount of data coming in and then looking at deep dive reports. And here we had a levers deep dive. So one of the sorts of things that if we're growing the size of our workforce, reducing the number of people that leave will mean that it grows faster than that. So people leave for a variety of very good and positive reasons. You know, they move areas, they go for promotions, they retire. What we want to do is to try and reduce those people that are leaving where we could avoid them from leaving. So really good look at this report. The information will be shared with our divisional teams. We'll have a look at the impact that they can have on those sorts of levers. The other area I'd highlight is just around equality and diversity and inclusion, and really pleased to note that we've got chairs now in place for all of our network groups. So these are staff that are doing this voluntarily because they've got sort of commitment and passion, and we want to make sure that they're supported in that. So our thanks go to those. And some really great work that the team did around what seems a technical issue about the cleansing of ESR. But there's lots of data that we hold about staff on our systems that's incomplete because it's been collected over a period of time. And the team have done a really good job at sort of tidying that up and reducing the amount of information that we know. So we've got a much better understanding now of the sort of gender, race, disability of our staff. And that means that we can get policies and procedures that support them more effectively. So some really good work there. And then also just in terms of the Workforce Insight report, where we just have a look at those charts, the data, the graphs I was talking about earlier when Hayley was talking about. And I suppose the thing I would want to highlight here is it's very easy as a sort of committee to look at a bit of data in isolation and say there's a worry or an anxiety about something because it looks to be in the wrong direction. And what we were particularly mindful of in this meeting is the work of our operational teams. So we often, rightly, I think, congratulate our doctors and nurses and frontline staff for the work that they do. But over the last 18 months, I think our operational teams, teams that work with Hilary and with Lynn, have done a fantastic job where we've got pressures on the services, changing the way that they're delivered, infection control, social distancing, increased amounts of absence because of COVID, and they're trying to just make sure that we're providing safe, high quality services for people, and they'll do that when there's vacancies by looking at things like agency spend or staff working overtime, but also want to make sure that we don't breach financial rules and that we're not suddenly putting too much pressure on our staff. And there's just a sense, I think, and again we wanted to pass that on to those operational teams, that we understand that. We continue to look at the data because there's areas that we can improve. Some of that was looking about how we can get better trajectories in terms of statutory and mandatory training, and we'll get reports brought to that to future meetings. But hopefully that gives you a sense of the work that's going on, both in terms of existing staff and how we can bring new staff into the organisation. I have to take any questions.
Thanks very much, Dean. Any questions? No? Thank you for that, Dean. Moving on then to item 15, Mental Health Legislation Committee. Mike.
Thank you, Chair. As you can see, we consider the Norfolk Safeguarding Report at this committee as well, and it's also been to board. And normally I would be a big fan of saying don't take things to all different committees, but the implications for patient care and for organisations from the treatment of these three individuals meant that it was important that we considered whether there was any legislative impact. And we didn't find anything that we found that we needed particularly to learn from a legislative point of view, so we were able to give it a light touch. We received the IPR, sorry about that, it says IBR report. It's the Integrated Performance Report, where we noted rising levels of patient acuity. And this we're seeing people who are more ill coming in through the door rather than a natural progression, so to speak, but this mirrors the national picture. We looked at the reducing restrictive interventions, really good report. It was highlighted by the use of case studies, and I'm a big fan of that because it brings it both to life and it also gives you an emotional attachment to the work that our staff are doing, so we complimented that. We also looked at another area of general safety. Safety seems to be coming through very clear on this, and that's MAPA, the Multi-Agency Public Protection Arrangements, which the committee have taken on from Audit Committee. And I had the privilege to attend a MAPA meeting, level 2 meeting in Hull, the details of which obviously have to remain confidential, but I was able to gain assurance as to the process that takes place and the wider implications and the sharing of intelligence, because we all sit here perhaps as members of the public, and when tragedies happen, we think, why wasn't that person monitored? Well, when the intelligence is there, it really is pulled together, and I was amazed at the work that was done in terms of seeing a full picture of any people in society who are deemed to be at risk or risk to others. Thank you.
Thanks very much, Mike. Any questions to Mike? No? Thank you very much for that report, Mike. That's received. And as we move on to the Audit Committee Assurance Report, Peter.
Thanks, Chair. So we had a meeting, I think it was on the 9th of November. So I'll take most of the report as read. I'll just highlight maybe 3 things. First of all, the internal audit assurance report. So we had 5 of those in the period. Really important areas as well. Clinical governance, a couple of the divisions were examined. Health and safety, business continuity, complaints management, and management of reports. 4 being significant and 1 getting the highest rating as well. So I think we were really assured that those areas were being well managed, and we were getting also a really good service from Audit Yorkshire, who became our internal auditors just over a year ago. So just to highlight that to the board. They also review our counter-fraud arrangements, and we do talk about getting an awful lot of emails into our accounts, don't we? But one that I always read is the counter-fraud alerts, because they are really important. I think the first port of call really to manage that is on a personal basis. So I would encourage everybody to read the counter fraud fraud alerts that come through, just to refresh, to make sure that you understand anything that comes through, and anything that personally you can do to sort of save a matter becoming a fraud issue. Then obviously it's that's where it starts. In relation to the external auditors, I mean, we are still unsure what the year-end timetable is. So we've got audit committee dates in May and June. So we don't know if it's end of May or end of June, or even the middle of June when we have to do the accounts for next year. But I think we should know that by middle to the end of January, so hopefully for the next board meeting. Just over a year ago, we had NHS Digital did a review of our cyber operational readiness, and as a result of that, we had an action plan. So we went through the latest cyber assurance report to see where we're up to on the action plan, and we're not doing too badly at all. But there are some which are maybe 6 months away, which are amber, which we just need to to keep an eye on to make sure that they come in on time as regards the actions being implemented. But apart from that, we received good assurance that the remediations that we anticipated to date had all been completed. I think that's the summary.
Thanks very much, Peter. Any questions? Thank you for that assurance report, Peter.
Sorry, Chair, I was going to say that it was also the last meeting, I think, of
Peter.
for Peter. So we did thank him for all his work he'd done on the audit committee, because he'd been an exceptionally good chair. So I think we should just note that at the board.
Absolutely.
Thank you.
This is Peter's last in-person board meeting. He's got a virtual one before then, but we're coming together for our development session as well. So you can have a long road to waving goodbye.
I've had a few of those, but thank you.
Thanks, Peter. Okay, moving on then to the Trust Winter Plan. Lynn.
Thank you, Chair. So this plan builds on the paper that I brought to board a couple of months ago. Really just wanted to provide probably a little bit more detail of some of the schemes really that are in our plan for this winter. Each of the divisions have a more detailed level plan supported by project reports as necessary. So, and obviously this high level plan has also been shared with our system partners as well. So through the system work, obviously what we do with our partners is just make sure that these plans are understood, where there's mutual interest, mutual aid potentially across the plans, then obviously that's addressed through those forums. So I hope it's fairly self-explanatory to the board. I'm just happy to pick up any particular questions that people have. As I've said on the front sheet as well, Michelle commented earlier, there will be further update at each board meeting now through the winter months on how we're actually implementing this plan going forward.
Yeah, and that's really helpful, I think, going forward as well. And it's a very good summary as well, I think, too. Questions to Lynn on this item? I mean, obviously, we picked up on some in the chief executive earlier on. Michelle, sorry, did you want to add?
Yeah, no, I'll just add, obviously, there's a lot of conversations and a lot of regional discussions around winter planning, both from a sector point of view vis-a-vis mental health and disability, but also an acute, but also across the system, which we're obviously contributing to and linking in with from a whole pathway. And they will continue over the next few weeks, if not months, because we are expecting and anticipating increasing challenges, demands and pressures, and a growing system that's under immense pressure from primary care all the way through. So we are contributing to those conversations and supporting each other as much as we can, both from a mental health and a community point of view, but also working really closely with the acute sector as well, and the ambulance service particularly. So it's just to give the board a little bit of reassurance in relationship to that bigger picture.
Thank you, Michelle. Peter?
Can I just ask, Michelle, about the ICS and in relation to bank staff, because I see one of the issues here is obviously bank recruitment campaign, and whether there's any like joint working between foundation trusts or other organisations to get a general bank together that can fill in at different trusts, to help out, especially during these months that we've got coming up, where there's winter pressures, there's maybe more staff on sickness for various reasons, and there's more demand for services. Sharing of these resources rather than each trust dealing with it in its own account.
I'm sure Lynn and Steve will want to come in, but we are looking at share banks across the system. And I think as the integrated care system starts to develop further, that will progress, I think, a lot quicker across banks. And I know we've spoken to North Yorkshire Council significantly about a bank from a local authority point of view. So yes, I think that's the bigger picture. In relationship to mutual support, we've done mutual support all the way through the pandemic, really. We've been actually really good from a sector point of view at sharing resources where we can across the patch. And we do continue to do that. And part of the reason for the winter planning meetings that we're having, specifically sectorial base, as I say, from a community, from a mental health point of view, is to see what else we can do in relation. Also need to be reminded that we do a lot of mutual aid. We also sometimes need that mutual aid back. So we just need to be careful that we maintain our own staffing position as well, which we do. But yes, we're constantly discussing those bigger pictures and those bigger systems issues at the moment. I don't know if Steve wants to add anything about the development of the ICS and HR processes, or if Lynn wants to come in any further about staffing and winter.
So just on bank, Peter, so some ICSs have got a shared bank up and running. Our ICS hasn't at this point. As Michelle quite rightly says, that is something that we flagged up as being beneficial and to be in place. So we would be an active participant in that if and when it gets up and running. But there aren't immediate plans to have that in our patch at the moment. And there's a variety of reasons to that. Some nervousness about people sharing banks and actually worrying that what will mean is that they will lose staff and be disproportionately affected by doing it. So that's where some of the nervousness is driven by providers in that. I have to say, we don't share that. Conversations Lynn and I have had is we would go into it openly, and we would be a willing participant and happy to share. So we keep pushing that, Peter, at an ICS level. As I say, there's no immediate plans in this area to have that up and running, though, but I am aware it's working successfully in other parts of the country.
And I just add, obviously, operationally, we've got some really good and robust mechanisms in place, Peter. So I think through the pandemic, particularly with our other mental health trust counterparts, we've got some good, really robust operational arrangements now, both in terms of sort of mutual aids around some bed capacity, which we talked about earlier, but potentially in terms of staffing as well. I think the other collaboratives as well, I was at the community collaborative yesterday, so there obviously is ICS discussions at operational level and really thinking about how we can take that further forward. Obviously the biggest pressure at the minute particularly is around local authority provision as well, so that was certainly what we were talking about yesterday, but I know that's going to be taken forward through the mechanisms that Michelle talked about too.
Hilary, I think you wanted to come in.
Yeah, just to say to the board around, I think it was Dean's earlier point about staff absence, sickness due to COVID, certainly for the absence where maybe you've been in contact with somebody that's COVID positive, which obviously with the increasing prevalence, our staff are more and more likely to come in contact or indeed have a household member. We do have quite a rigorous risk assessment that we undertake with staff, whereby we can actually bring them back. If the risk assessment obviously is that way. So it's certainly if it's a household member, I sign those off. Managers would sign off if it's just sort of general population, friends, etc., not household members. And I think, again, we just need to keep encouraging our staff to send them in. I haven't had a great deal. I have signed 2 people back in, but I think that is, again, another thing that we can do, particularly given the prevalence and the likelihood of our staff coming in contact will increase. So I think we do need to keep that in mind as well.
Thanks very much, Hilary. Anybody else? Sorry, Dean.
Yeah, thank you. Thank you for the plan, Lynn. And I know it's called a winter plan, but I think it's widely predicted, isn't it, that this winter for the NHS is going to be the most difficult winter that we've ever had. And things like flu, what will happen in terms of restrictions and social distancing, travel arrangements, and that's before we even get to weather and snow and everything else that's coming. So I suppose it's really positive, Lynn, to see that, but we also recognise that this has probably got to be the most flexible and adaptable plan that there's ever been, and we know that back to the point I was making about operational teams is that ability for them to use their judgment and their skill to be able to sort of be getting us through this period as safely as we can.
Yeah, absolutely.
Okay. Yeah. Thanks for that, Dean. Point well made. Anybody else? Okay. Thank you. And obviously we'll be having these reports monthly coming back to us. Thanks, Lynn and everybody. We move on now to John, Health Inequalities and the Humber approach.
Okay, thank you very much. So we have a presentation here, Chair, which we'll be able to put up on the screen so people viewing us will be able to watch. It's just a quick few slides, and I think it'll just hopefully generate a little bit of conversation, particularly with regard to Hayley story, which we presented earlier on. So
sorry, Chair. I thought we were just.
I thought we were going to have the paper come back. Sorry,
come back with a full more detailed paper in relationship to the organisation, its anchor status, and where that. So that was my impression. So if I've misunderstood that, Chair and John, that
yes,
we sent the presentation out.
Yeah. So my understanding, John, you were going to talk about a presentation bringing back to the next board meeting that would take us through some of the specific issues around Humber and inequalities at the next one.
I'm happy to do that, Chair. I was asked to do a presentation, so look, we're happy to bring that board at the next one. That's fine.
Thanks. Okay.
Is there anything you want to highlight, John, that was on the presentation? Yeah.
Well, no, I think the nature is the presentation. I think we just, me personally, reflect back to Hayley's story where he talked about health inequalities. And actually, for reality for me is Hayley's story starts with the social inequalities and the fact that she's living in a caravan which has holes in it and has a desperate social circumstances. And what we're trying to do, we're running really quickly in health to keep up with the demand that is created by social inequalities. And I think that's important that we do run as fast as we can and we increase capacity. But the reality is, in terms of our hard-to-reach communities, that unless there's some action taken with regard to social inequalities, I fear we'll always be looking at our waiting lists and our, some of the tricky outcomes and going, what more can we do? So to be honest with you, maybe this is something the ICS really needs to pick up and run with, and we don't make the mistake and fall into the trap that this is all about health inequalities, because my personal view is it's not. I think we can make health inequalities worse, but unless we focus and target the social inequalities which exist, particularly along the East Coast and some of our urban areas, and we can see that with flu uptake and all sorts of things, I think the NHS is always just going to be running really quickly to stand still, and we can see that with some of our CAMS demands. So it probably doesn't need a board presentation or a paper to me explain as what is the obvious, but I think sometimes we're losing that, Chair, if I'm honest, because that's
It's a point well made, and one of what we should be looking to get out the ICS is a correlation of data coming from different partners to paint that picture. Local authorities have a huge amount of data on social inequalities, and there's other bodies that have that too, and where we can align that next to the health inequalities, I think that hopefully that presentation that we'll come back to will enable us to see particularly where within our patch that issue is most obvious and where we need to play our part, but also others need to play their part as well. There's a huge amount of data that's out there that we can pull together on this, I think. But yeah, if we could have that at the next board meeting, that would be great.
And I think that's really good. And John does a great job at championing social and health inequalities at the ICS, and I know has lots of conversations as well. So we can feed that in as well.
Definitely.
There'll be a really good conversation and maybe a bigger slot for it as well.
I think so. I think we want to do that justice. Okay, moving on then to the Council of Governors report, which actually was the 8th of July, which I wasn't the chair at that time. Others who are more participatory than myself might want to say something, but I think actually just looking back through the minutes, we've obviously had another Council of Governors since then, and quite a lot of activity with our governors. And I think part of their ask has been obviously some of the issues we've touched upon today that we think are important, they think is important too, and we're trying to make sure we facilitate information that is really helpful to that end. But also, I think it's fair to say as well, we've had a lot of new governors come on who, because of the situation and not being able to meet in person, part of our discussion since this particular meeting of the council is to think about how we, I suppose, recover for them as a group. And I think there's some really positive work going forward on that front. And thank you to members of the board who've been involved in that and helping to facilitate that. Any questions on those minutes, or are we accepting and noting them? Brilliant. Thank you very much. We move on now to board assurance framework, and we've also got the risk register update, and hopefully we've got Oliver online with us, Oliver Sims. No, he's not online with us. So if someone could find out what's happening with that, Michelle.
Shall I start on the board assurance framework? Hillary, if you can just check that with all of us. We were expecting him, I think, as well, Jenny.
Yeah, 11.
About 11 o'clock. I think we're more or less bang on time. Sorry, after 11, I think we said. Board assurance framework. We have had quite a lot of conversation about the board assurance framework at the executive management team. So some of the conversations haven't actually fed into this report, but will do, and Oliver will take you through that. It is one of those movable feasts in relationship to the board assurance framework. It'll be interesting to see what the well-led review says in relationship to both that and our risk register. So as you'll see, going through the strategic goals from 1 to 6, overall the rating has been maintained. Obviously, there's been some fluctuations within that, but when we've looked at them, we've sort of said that we're roughly about where we were. So there's been no increases or no decreases. We're still, obviously, we did the risk appetite, so there's no change on that. And we have tried to pick up some of the conversations that we've had at board before in relationship to gaps in assurance and other actions as well, and try to keep those more up to date. So I think you'll hopefully see some movement in where we've been following the board discussions previously. I know there's still more work to do, and that is in progress. As I said, we have had some conversations. I think one of the things we did suggest it would be useful if sometimes to explain the reasons, because sometimes people are saying, well, if you've got a red, how can you be yellow? Or if you've got 2 ambers, how can you be green or whatever? So we were going to do something on the front sheet. So apologies, we'll make sure that's in for next time. But we have reassessed all of the various strategic goals, the levels, and maintained where we're at. And I think we're all in agreement with that. And obviously, the relevant directors can add anything further about their particular area. My 2, for example, fostering integration partnerships and alliances, I do think we're continuing to do that active engagement. I do think we're continuing to develop those partnerships. I do think that we're having the ongoing influence in relationship to the wider ICS, but also in some of the smaller, the smaller organisations, the smaller groups as well. And then the promoting people, community, social values. We've had a great social values report that John led, which has been published. And obviously we'll be working through the next one. We've got a great amount of co-production that Mandy and the team do. So they're the 2 for me, which is why we've maintained, though we've said they're both still at green. I'll leave it there, Chair. I'm hoping
we have Oliver.
And we have Oliver. So I'm hoping Oliver heard that and isn't going to... I hope that was a good report, Oliver, in relationship to the board assurance framework. So I don't think there's much more to say on that, unless you want to add any major points.
Welcome, no, Oliver. Thank you, Michelle. I think it was really comprehensive. Thank you, everybody. I think the only point to add, you mentioned around sort of the individual rationale for the scores. We have added a paragraph just to justify our overall sort of scoring mechanism, and that what we're seeking to include is an overall assurance rating, encompassing obviously those things that aren't scored in terms of risk ratings, but also the overall positive and negative assurance for the quarter, as well as looking at the scores on balance of each of the aligned risks. So really much a joined up approach in terms of looking at all of different aspects to come to the score. I think previously, I think there'd been discussions around individual strategic goals where we did have a high related risk to that particular strategic goal, and why didn't that then transfer to the assurance rating? So it's very much that sort of overarching balanced approach now to looking at the score. I think what you mentioned, Michelle, around the point of justifying each of the scores going forward, that is something that we're going to be considering and will be up and running by Q4. And I'm going to be working closely with Claire Jenkinson, obviously the Deputy Chief Executive Officer, just to reintroduce some of the performance elements into the BAF document in line with ODG review as well. So we sort of have that ODG involvement as well as obviously XX sign-off involvement as well each quarter. So really sort of trying to bring it on a little bit further, but I think that's a fair representation of Q3, and obviously it's been for the board subcommittees ahead of coming to board as well. So hopefully represents the current position that we're in and gives a good sort of account for the organisation for Q3.
Thank you very much, Oliver. Are there any questions to Oliver or comments colleagues would like to make on this report? No? Okay. In that case, that's received and noted. Can we move on to the risk register update, Oliver, please?
Certainly. Thank you. Update report. We're currently register, so risks that have a current score of 15 or above as per our scoring mechanism. You'll notice there has been some slight change in terms of some risks that have now been closed off that appeared in the Q2 version and now been reduced, so they're being managed either on directorate or divisional risk registers, and those risks were F25, which was the risk around the consultant vacancies. What we looked to do with that particular entry was just to limit it to being the quality and safety impact linked to the current level of vacancies within the organisation. And I think it was felt, based on looking at it from that perspective, that brought the sort of the likelihood of that risk being realised down. So that's currently sitting with a score of 10, does still sit on the Workforce and OD Directorate Risk Register, will still appear into reports into ODG and the Workforce and OD Committee. So we're still keeping a close eye on that risk. It just doesn't appear on the trust-wide document currently. And then there were two operational risks that had previously been escalated from the divisional risk registers, which are SR29, which is the risk around clinical activity in Scarborough Community Services, which again, based on the controls that have been implemented and obviously the mitigations that we now have in place, it was felt that score needed to come down. So that's been readjusted and brought down to a current rating of 12. The risk does remain live, does remain being managed on the divisional risk register. So again, it does go through assurance processes via ODG and escalations where required to EMT. So obviously that risk will still be managed as such, but obviously it's at that reduced level. And then finally SR15, which was a risk that appeared on the Q2 version of the trust-wide risk register in relation to vacancy rates at Fitzwilliam Ward in Malton. Again, based on the current level of recruitment and the vacancy situation on the ward, and again, the additional mitigations and controls that were put in place, it was thought that score would also come down. So again, reduced to a current rating of 12, continues to be managed on the divisional risk register with updates to ODG and EMT as required. And I think the only other point to note is just in terms of the overarching risk registers for the organisation, slight change from September's position to November with an increase of 21 risks, but that's across the board. No one area with substantially increasing numbers. And again, just reflects that obviously the risk register process is very dynamic, and we do often see the changes in numbers as those risks do get reviewed and closed and opened as required. So again, really good progress in terms of the risk register arrangements. Obviously, we'll continue to improve it as best we can and take it into the new year. Obviously, there has been challenges up to this point with COVID and various different things, but I think we're coming very much to the end of that in terms of our arrangements, and now things are working very well through our implementation of MS Teams and obviously Datix dashboards as well, which is really sort of paying dividends in terms of keeping that process really live and working well across the trust.
Thanks, Oliver. Hilary, would you like to add anything to that as a lead?
Just a comment really that, I mean, the main risks on here are workforce, waiting times and out of area, given that this is a dynamic document, and that actually fits with most of our discussion today, doesn't it, as a board, is around those areas. So I think that's quite reassuring in terms of this document being aligned to what we see as the board as being our big risks.
Yeah, that's a very helpful point. Thank you for that. Any questions or comments anybody would like to make? Peter?
Yeah, I'll just say that there are quite a lot of risks that are at risk level number 12, and also some at number 10. There's like 71 in total. And just to say really that in terms of the divisions, we have a deep dive every audit committee into one particular division with divisional staff coming in to sort of explain the risks and for us to gain assurance on how they're being actively managed. So although they don't appear at board level, the audit committee is seeing the 10+ risks and discussing those with the relevant staff, just to give the board assurance that we'll actually go lower than this in terms of the overall assurance of the board and its committee.
Yeah. So there's an active engagement there
Yeah.
before it's coming here in terms of these reports, which is good to hear and good to be reminded of, I think. Thanks for that, Peter. John.
Just a sort of an observation, I think over 3 and 4 years wearing my clinician's hat, this particular risk register feels really real and pertinent to the challenges that we face. I think historically we might have had a lot of risks on the register relating to income and finance. I'm not saying they're not important, because they are in terms of sustainability, but in terms of the things that we think about at an executive management team, and particularly an ODG and the managers who run the organisation, you could have a lot of things on the risk register, but this to me feels like the pertinent things, particularly when we talk about workforce, which we mentioned earlier on. Is this a risk? Absolutely. But actually the growing demand on our services and the acuity. And I think our risk register just feels a little bit more real in terms of what's going on in the organisation, and that has positively evolved over time, I think.
Yeah, thank you for that, John. Anybody else? Okay, thank you, Oliver, for being with us today, and we'll be seeing you again soon, no doubt.
Thank you very much, everybody.
Thanks, Oliver. Items for escalation. I haven't received notice of any items for escalation. No. Any other business? No. Okay, well, thank you, everybody. We're going to now adjourn now before we have our private session, and members of the public who may be watching are not part of that second part of this meeting because, of course, the confidential nature of the business that we may be discussing. But thank you if you've joined us today. And don't forget, go to our website if you want to know more about what our trust is doing. You're very welcome.
Thank you.